Hello, my name is Becca Fredrickson, and I'm a third year occupational therapy student. Today, I'll be presenting on trauma-informed care in the pediatric occupational therapy setting. Trauma is defined by the American Psychological Association as an emotional response to a terrible event, such as an accident, rape, or natural disaster. These events are deeply distressing and result in physical or psychological trauma. It is important to know that trauma can still occur in secure relationships, and it's also important to remember that it's an individual's experience of the event, not necessarily the event itself, that is traumatizing. There are three main types of trauma. The first is acute trauma, which results from a single distressing or dangerous event, such as an assault, a hospitalization, or a natural disaster. The second type is chronic trauma. This results from repeated, prolonged exposure to highly stressful events such as sexual or domestic abuse, bullying, or long-term illness. And the third type is complex trauma. This results from exposure to multiple traumatic events or experiences, usually within interpersonal relationships such as family disputes, childhood abuse, or neglect. Adverse childhood experiences, or ACEs, are traumatic events including witnessing or directly experiencing abuse, household changes, and neglect from within the home or community. These events lead to an excessive activation of the stress response system, also known as the fight, flight, freeze, and fawn responses. Stress and trauma, especially when it is prolonged, can interrupt healthy child development, which then puts children at risk for developing lifelong health issues. Here is an example of an ACE questionnaire. The more yes answers, the higher the ACE number, and the higher ACE number correlates with more negative health outcomes. Unfortunately, ACEs are extremely common, with 67% of the population having at least one ACE and 1 in 8 people having more than 4 ACEs. Stress and trauma in childhood can lead to lasting health effects into adulthood, including health difficulties such as obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, and broken bones. It can also lead to behaviors such as smoking, alcoholism, or drug use. ACEs can have lasting effects on an individual's life potential, including lower graduation rates, decreased academic achievement, and lost time from work. Traumatic events have the most pervasive and vast effect within the first 10 years of life. Trauma has an effect on the cellular level, with consequences on the child's physical, emotional, developmental, and behavioral health across the lifespan. Trauma can cause a child to become more hyper-alert. Children who experience repetitive trauma become hyper-alerts to threats, even when there are none present. This leads to difficulty determining between a threat now and a threat then. Children who experience trauma may also have a larger amygdala. Due to the child being hyper-alert of threats, their body is in near constant fight, flight, freeze, or fawn response. This constant flow of stress hormones can cause structural changes to the brain, including a larger amygdala. Similarly, when a child spends prolonged time in fight, flight, freeze, or fawn state, also known as the survival brain, the more difficulty they typically experience regulating their emotions, sensory systems, and time. These children may also experience difficulties with communication and memory. Children who experience trauma may also have learning difficulties. The longer a child spends in survival brain, the harder it is for their learning brain, their cortex and frontal lobe, to take over and for the child to be in a place to absorb and learn new information. We all have a window of tolerance in which learning can occur. You may have heard this referred to as zones of regulation. Essentially, a child who is dysregulated is not in a place where they are able to learn. They are currently working in the lower or survival brain, and they are unable to process and file new information in a way that is needed for learning. Children who have experienced trauma are often working out of the survival brain, meaning their window of tolerance for learning may look different than their peers. It is important as OTs working with children who may have experienced trauma to understand that a child will naturally fluctuate between these states, and we can help them return to a learning zone. However, we can't expect their performance to be great when they are outside of their window of tolerance. I think this visual does a great job of depicting the emotion states we can see a child in when they are working out of survival brain, either hyper or hypo responses. and not able to take in and process information for learning well. However, on the flip side, this image also shows what it looks like when a kiddo is in that regulated and ready to learn zone. Trauma-informed care can be thought of as a framework of thinking and interventions that providers can use that are directed by a thorough understanding of the profound neurological, biological, psychological, and social effects trauma has on an individual. A trauma-informed care lens recognizes a person's constant need for safety, connections, and ways to manage emotions and impulses. I really enjoy this quote from Karen Sockvitney about trauma-informed care that says, "Trauma-informed care is about the right to have a present and a future that are not completely dominated and directed by the past." The Substance Abuse and Mental Health Services Administration, in conjunction with the Center for Disease Control and Prevention, created 6 guiding principles to a trauma-informed approach. They are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. These 6 principles align well with our occupational therapy practice framework to provide strengths-based and client-centered care in everything we do. So, how is addressing trauma in children within our scope as occupational therapies? We address engagement in occupations. We are skilled professionals in helping our clients engage in health-supporting habits, rituals, and routines. We utilize client-centered interventions to address any barriers to occupational engagement. We also address sensory regulation. We are skilled in assisting our clients in identifying and regulating their sensory system through play. We understand that a child must first be regulated in order to learn. We also utilize relationship-based interventions. We are skilled professionals in providing interventions that are client-centered and that build rapport and attachment with the children we serve. We are also experts in utilizing a coaching method to support the parent-child relationship. Lastly, we are skilled professionals in child development. We work in early childhood settings, and we are experts in recognizing and addressing developmental milestone delays in children that may occur when they experience trauma. Now that we've discussed why addressing trauma is within our scope as occupational therapists, let's discuss how we address it through evaluation. First, by utilizing a strengths-based approach. Instead of initially focusing on all of the negative impacts the traumatic effects have had on the child, build rapport with them by figuring out their interests and their strengths. Establish yourself as a trustful adult to the child. Second, focus on the impact on occupation. We do not always need to directly discuss the specific traumatic events during evaluation. Instead, it's more important to create a safe space and discuss the impact those events have had on the child's occupational engagement. An evaluation of sensory processing should be completed routinely to determine if sensory processing difficulties are also affecting the child's participation. Next, let's discuss how to address trauma through intervention. We can address trauma through sensory regulation. When a child's sensory system is dysregulated, they are not able to effectively learn during occupational therapy sessions. Interventions such as gentle rocking, swinging, deep breathing, deep pressure proprioception can be beneficial to bring a child back to a regulated and ready to learn state. Self-regulation is an important tool to teach children who have experienced trauma. Each child has their own preferred method to bring their body and mind back to a calm state, such as breathing, mindfulness, slow movement, or even taking a break outside. It's also important for the occupational therapist to practice co-regulation by modeling their own state of calm to bring a child back into a state of regulation. A child's sensory and attachment needs must be met first before we can attempt to build any occupational competency or to gain new skills during your session. As occupational therapists, it is important that all of our interventions are client-centered. This means the task is matched to the individual's interest, current developmental level, and occupational needs. Remember to offer choice as often as possible, engage in child-led play, and alter your expectations depending on the child's sensory regulated state. We can utilize the coaching method to teach parents and caregivers of the child the important role that they play in creating a safe and stable relationship with their child. Attachment and co-regulation are crucial in addressing children who have experienced trauma's occupational needs to help them feel safe, supported, and regulated. We utilize therapeutic use of self by establishing trust, safety, and a sense of fun in our sessions. Children who have experienced trauma are often on high alert of who they can and cannot trust. By establishing yourself as a trusting adult over time, the child will be more likely to buy into your therapeutic expectations. Lastly, by utilizing schedules and routines within your sessions with your pediatric clients, this can help ensure a sense of safety and predictability. These children are often living in a constant state of fight or flight and are on edge looking for the next threat. By establishing a schedule and routine, we can demonstrate transparency and safety with these clients, showing them that your OT sessions are a supportive and trustful place to be. They know what to expect when they come and see you for OT, allowing them to hopefully come out of a heightened state and enter into their learning zone. Now, let's try some intervention activities together. These activities target self and co-regulation and sensory regulation, and they can be used to help calm the body and mind when the child is in a heightened state. First, let's try spaghetti noodle holds. Hold your body straight out and tight like an uncooked spaghetti noodle. Hold for 5 seconds and count out loud together. 1, 2, 3, 4, 5. Then relax your body and become loose like a cooked spaghetti noodle. This activity utilizes isometric muscle contraction and relaxation to reduce anxiety and stress. This is also a silly and fun way to build rapport with your client. Next, let's try box breathing. Breathe in and count to 4 slowly as you feel the air enter your lungs. Hold your breath for 4 seconds and then exhale slowly for 4 seconds. Imagine each breath and each exhale being the side of a square or box. Repeat this inhale-exhale pattern until recentered. Deep breathing calms the sympathetic nervous system that keeps children in survival brain. Mindful breathing affects the physiology of their nervous system while also bringing them back to the present moment. Now let's talk about slow rocking. Try rocking on your back with your knees tucked into your chest. Practice this movement and rhythm for a count of 30 and then reset. Repeat until recentered. Gentle rocking and tactile input can provide grounding to bring a child who is in a heightened state back to a regulated and ready-to-learn state. Often, children who experience trauma don't know the difference between adults that they can and adults that they cannot trust. Establish yourself as a trustful adult throughout your occupational therapy sessions with this child. Here are some affirmational statements that you can use with a child who is in a heightened state. You could ask, "How can I help?" Remind them that they are not in trouble. Affirm their experience by saying that you had no idea how hard this was for them. Bring them back to the present and ground them by saying that they are here and they are safe. Remind them that you are listening and that you believe in them no matter how they feel about themselves. Secondary trauma or compassion fatigue can occur to individuals serving those who have experienced trauma. This is the emotional distress and trauma symptoms that can result from hearing about firsthand trauma experiences from someone else. I surveyed occupational therapists from around the country who are working in pediatrics and utilizing a trauma-informed care lens on how they protect themselves from secondary trauma, and here were some of their tips. Establish boundaries. Practice regular and proactive self-care and self-regulation. Diversify your caseload. You don't have to have all kiddos who have experienced trauma. Establish frequent and supportive mentorship. And celebrate the small wins. Remind yourself of the progress your clients are making, no matter how small. Thank you for listening to my presentation. Here are the references I used.